Hello and welcome to our second live event tonight. It's 8 p.m. UK time, so it is time to start it. IVF webinar this time, and of course, I'm glad to be back. And I hope you have lots of questions as we are having another interesting topic to discuss, and yet another expert in that is here to help you. Dr. Jose, how are you feeling? And please let me know that you can hear me loud and clear as well.
Yes, I can hear you perfectly.
Excellent. Happy to hear this. So first of all, let me start off that we are gathering here every single day so that we can support you through those uncertain times. Of course, now the clinics are reopening, but I know some of you are still not able to go ahead with the treatment. So we are simply here to guide you, to provide you with as much details and topics as we can so that you can use that time and get prepared for your treatments. And fingers crossed, you are able to go with the treatments very, very soon, of course, as well. And all those events, they are all brought to you thanks to our ambassadors and partners as well. You can see all of them right here. Some of them you already are familiar with, as we already had some webinars and online patient meetings. Some of them will still have their events. So huge thanks for their support. And I've already mentioned we have another special guest. This time today, it is Dr. José Bellver, attending gynecologist at IVI Clinic, which is located in Valencia, in Spain. And he will discuss today a topic on female obesity, fertility, and pregnancy. What do we need to know before IVF? So we will start with his presentation. And after that, it will be time for your questions. So please prepare your questions. You can type those questions either during the presentation or later on. And don't miss that chance to ask your questions. I am sure Dr. Jose will be happy and will definitely help you out. So I encourage everyone to go ahead and type those questions. And this is being recorded as well, so you will have a chance to rewatch it at a later time as well. And that is it from me at this point. Dr. Jose, are you ready to begin with your presentation and ready to go
Yes.
ahead with our webinar?
Okay, yes, Caroline.
Excellent. Thank you so much. Then go ahead.
Thanks to you. Good evening to all of you. In my presentation, I'm going to comment what is the effect of female, but also of male obesity on conception, spontaneous conception, and assisted conception. And at the end of my presentation, I will give you also some information briefly about the effect of female obesity on pregnancy and postnatal life in the offspring. The definition of the definition of obesity is based on the body mass index. Body mass index is the relationship between weight and height in kilograms per square meter, and is considered that normal weight is up to 25 of body mass index. From 25 to 30 is overweight, and above 30 is obesity, with different degrees according to the level of obesity. So what is considered a pathological condition is to have a body mass index higher than 30. Regarding spontaneous conception, for many years, there are many studies that have shown that female obesity is related to an increased risk of subfertility. Subfertility means that the time to achieve pregnancy is longer than expected. For instance, in these two studies, you can see that as body mass index was higher, the time to obtain a pregnancy was increased. But female obesity is also related to infertility, so no having any pregnancy. In this study, for instance, it was determined what was the risk of infertility when an adolescent woman presented obesity. So the presence of obesity during adolescence was related to a 3 to 4-fold increase in the risk of lifetime nulliparity and nulligravidity. This means that the presence of obesity during adolescence was related to 3 to 4 increased risk of not having any pregnancy during lifetime, or having the pregnancy but not having finally a live birth because several complications during pregnancy. So female obesity is clearly related to subfertility and infertility. It was believed for many years that the almost exclusive mechanism related to subfertility and infertility in obese women was the presence of ovulatory disorders. In this figure, you can see that as body mass index is higher, the percentage of ovulatory disorders, incorrect ovulation or no ovulation, is increased. However, later studies show that even in obese women with regular menses with normal ovulation, there was a significant reduction in spontaneous conception. In this figure, from 29 of body mass index, per each 1 unit of increase in the body mass index, there was a 5% significant decrease in the chances of pregnancy within a year. That is the same effect that occurs with each year of advance of maternal age. So this means that despite the fact that the main mechanism of infertility in obese women is bad ovulation, incorrect ovulation, and ovulation, problems related to ovulation, of course, there are other mechanisms that also affects women with normal ovulation. And in addition, male obesity has been also related to infertility, but the main problem is when there is a combination of obesity in both members of the couple. That is frequent as they used to share similar lifestyle behaviors. In the first table, you can see that the authors tried to determine what was the risk of subfecundity, defined as a time to pregnancy more than 12 months. And you can see that as body mass index was higher in both men and women, the risk of subfecundity was higher, but was maximum when both members of the couple present obesity. And the same happened in the second table. In this table was established what was the fecundability odds ratio. The fecundability odds ratio is the chances of having a pregnancy per month of attempt spontaneously. And you can see again that when both members of the couple presented a body mass index higher than 35 is when the fecundability odds ratio was lower. So this means that female and male obesity are affecting the chances of a spontaneous conception, but when there is a combination of both of them, the deleterious effect of fertility is stronger. So if we have seen that obese women present an increased risk of infertility, they are more prone to undergo treatments of assisted conception. And the first problem that we face is that the ovarian response to any kind of medication that we administer is reduced. So, as you know, for ovulation induction and for in vitro fertilization, we need to develop more than one follicle, more than one oocyte or egg, and this is mediated by the medication that we give. In obese women, due to several mechanisms, but one of them is the higher volume of distribution of the drug, less amount of this drug reaches the target organ, that in this case is the ovary. So the result is that the ovarian response is always reduced in comparison to normal weight women. And in fact, the ovarian response to any kind of medication is negatively correlated with the body mass index of the patient. But this is not the only problem. The problem is not only the worst ovarian response obtained, but also the poorer results of the treatment. In vitro fertilization, as you know, we stimulate the ovaries, we take the oocytes or eggs are exactly the same, we fertilize them with the sperm of the partner, and we introduce one embryo inside the uterus. In the cases of in vitro fertilization, 1 decade ago, we published a study that to date is the largest single-center study performed about the effect of body mass index in women on the results of IVF. And in this study, we analyzed 6,500 cycles of IVF. And as you can see, when the body mass index of the patient was higher than 30, there was a significant reduction in all the parameters of outcome. This means implantation rate, or the chances of the embryo to implant into the uterus, pregnancy rates, and live birth rates. These results have been then corroborated by other multi-center studies, usually from the United States, with bigger sample sizes. You can see, for instance, this study that included more than 45,000 embryo transfers, in which, again, as body mass index was higher in the patient, the chances of having a clinical intrauterine gestation was significantly reduced. And this effect was dose-dependent. So the higher the body mass index of the patient, the higher the chances of not having a clinical intrauterine gestation. And the same has been shown in even bigger studies, like this one by Provost with more than 200,000 cycles of IVF, or this by Kawas with near 500,000 cycles of IVF. The message is always the same. When the patient has obesity, there is a significant reduction in implantation, pregnancy, and live birth rates. From a clinical point of view, in order to know if female obesity affects more the egg or the uterus, the best model that we have is the ovum donation model. Because in ovum donation model, we take the oocytes, the eggs, from a donor, we fertilize them with the sperm of the partner, and the embryo that is obtained is introduced in the recipient of the donated ova. So, if the donor is overweight or obese and the recipient is normal weight, we can see what is the clinical effect on the oocyte. But if the donor is normal weight and the recipient is obese, we can see what is the clinical effect of the obesity on the uterus. And additionally, we have to consider also the clinical impact of having a partner that is obese. Regarding the ovum donation model, there is one study in which recipients presented similar body mass index, and the authors analyzed what was the effect of having in the donor an increased body mass index. And you can see that when the donor presented a body mass index in the highest quartile, that is between 25 and 34 of body mass index, so overweight or obesity, there was a significant reduction in the clinical pregnancy rate in the recipient. So this study tells us that there is a negative impact on the oocyte quality. And regarding the other way to analyze the impact of obesity on the uterus, there are two studies. There are more studies, but these are the most important ones. This is unicenter and this multicenter. And in both studies, oocytes from normal weight donors were donated to recipients with different body mass indexes. And you can see that in this one from 30 and in this one from 40, the results in the ovum donation model using oocytes from normal weight women were poorer. This means that female obesity in the recipient is altering the endometrial receptivity. So from a clinical point of view, using this model in both sides of the donor and the recipient, we know that obesity is affecting both oocytes and uterus. And when the male partner is obese, there are many studies that have been summarized here, in which, again, the presence of male obesity was related in IVF, in vitro fertilization, to reduce clinical pregnancy and live birth rates. So from a clinical point of view, it's clear. The presence of female obesity and male obesity is deleterious for spontaneous and assisted conception. of course, is more important the role of women because the effect is on the oocyte, on the uterus, and then on the pregnancy. And in men, is only on the sperm. The second step is to determine from a research point of view what is the exact damage that obesity is exerting on both gametes, sperm and oocyte, embryos, and endometrial receptivity. So the question is, how is the alteration of all these components? Regarding men, we have seen that male obesity is related to a reduction in spontaneous and assisted conception. This is clear by clinical studies. But curiously, those studies that have tried to determine if sperm quality is altered in obese men have not reached any consensus. You can see here in this summary that there are studies that have shown that in obese men, there are alterations in the sperm in terms of number, motility, and morphology. But there are other studies with no alteration, and those studies with alterations usually do not agree about what kind of alteration is common in these men. The same happens for embryos. In this study, for instance, of in vitro fertilization, you can see that when the man was obese, there was a significant reduction in live birth rates. But when the authors compare the embryo quality based on morphology of the embryos according to the range of body mass index in men, there were no significant differences. So this means that something is happening, but we cannot see this problem. And the same happens in women. From the point of view of research, what alteration occurs in the egg, in the embryo, or in the uterus? For many years, many studies have tried to ascertain if obesity in women alter oocyte and embryo quality, but you can see that there is no consensus. In fact, in the study that I have shown you before, that we published 1 decade ago with 6,500 cycles of IVF, we analyzed more than 80,000 oocytes and their corresponding embryos. And despite the fact that we saw that there was a significant reduction in implantation, clinical and pregnancy, in implantation, pregnancy and live birth rates when the body mass index of the patient was higher than 30, we didn't find any correlation between the body mass index of the patient and the embryo quality the day in which we perform the embryo transfer. So this means that probably the way we determine what is the quality of gametes, sperm and oocytes, and embryos in the lab, that is based in morphology, in specific points of the development of these gametes and embryos, is not enough to see what is happening with these cells by the effect of obesity. And this is why we had to move some years ago to other ways of analyzing what was happening here. One way was by morphokinetics, that consists in not analyzing the embryo only like a photograph in specific points of the development, but knowing what is the continuous division of the embryo, what are the times spent between one division and the following division. And this was possible due to the time-lapse incubators, such as EmbryoScope, in which you have a video camera filming each one of the embryos. So you can film the embryo 24 hours a day, and you can establish if the times of division are normal or not according to different conditions. One of these conditions is obesity, but unfortunately, we didn't find differences in the times of division of embryos according to the origin from obese or normal weight patients. But what we saw, in another study some years later, is that the embryo function was different between embryos coming from obese or from normal weight patients. In this study, what we analyzed is the culture media in which the embryo develops during the time that is in the in vitro fertilization laboratory. As you probably know, they are in incubators, and they have like a fluid similar to the fluid that exists in the fallopian tube and in the uterus, a fluid from which the embryo takes substances and excretes other substances. So an indirect way of knowing how is working the embryo is to analyze what are these substances. What we did in this study is to take the culture media from embryos of good quality, good morphological quality, that we have transferred in women, and we compare the metabolites in this culture media according to the origin of the oocytes, from obese or normal weight women. And what we see was that despite the same morphology, the same good quality from a morphological point of view, the culture media from embryos coming from obese women presented some differences in the metabolites inside. Specifically, there was a reduction in the percentage of saturated fatty acids. So this means that with the same morphology of the embryos, they are working in a different way, and probably this is related to some of the problems and the poor outcomes that I have described before. And finally, we also studied what was happening in the endometrial receptivity, because in the ovum donation model, we have seen that when the embryo comes from a normal weight donor and we introduce the embryo into the uterus of an obese recipient, the results are poorer. What we did some years ago is to analyze the pattern of gene expression in the moment in which the embryo implants. Probably you know that after ovulation is released a hormone from the ovary that is called progesterone, that transforms the endometrium, that is the internal layer of the uterus in which the embryo implants. And after 6 to 7 days, in the so-called window of implantation, this endometrium is receptive. The way to know if it's receptive is analyzing the genes that are inside the endometrium that are expressed in different way when the endometrium is receptive or not. So we compare with normal controls, women with normal fertility, what was the expression of these genes in women with obesity, and especially in association with polycystic ovary syndrome. That is a syndrome of incorrect ovulation that is commonly related to obesity. And what we observed was that the expression of genes of these women was really similar to other refractory conditions of the endometrium, such as the presence of an intrauterine device used for contraceptive purposes. So it was more close, this pattern, that with the pattern of women with normal fertility. Some years ago, these genes were introduced in a chip that is commercially available, that is called the ERA test, endometrial receptivity array test, in which you can analyze 238 genes related to implantations during the window of implantation. And what we did is to determine if the percentage of non-receptive ERA tests, so ERA tests that showed that the receptivity was not okay in the moment in which it has to be okay, if the non-receptive endometria were related to the presence of obesity. And as you can see here, as body mass index was increased in orange, there was a higher percentage of non-receptive endometria. So this means that the presence of the endocrine and metabolic disturbances in the body of an obese woman is altering the expression of genes in the endometrium that are related to the embryo implantation. But the problem of all of this is not only the achievement of pregnancy, but also the development of this pregnancy. In pregnancy of obese women, there is an increased risk of miscarriage during the first trimester, and this has been shown in natural conception, but also in assisted conception after in vitro fertilization. The main origin in humans of first trimester miscarriage is aneuploidy. This means to have embryos with chromosomal abnormalities. For instance, as you know, with advanced age, there are more oocytes and embryos with chromosomal abnormalities, and this is why the risk of miscarriage or Down syndrome is increased with age. So if we saw that in obese women there is an increased risk of miscarriage, we could think that probably is because obese women are generating more oocytes and embryos with chromosomal abnormalities that are called aneuploid. But some years ago, we analyzed in the products of conception, this means the tissues from miscarriages, if the percentage of euploid and aneuploid, that means the percentage of normal, chromosomally normal embryos and chromosomally abnormal embryos was different according to the body mass index of the patient. And we didn't find differences. This means that the risk of miscarriage is increased, but it's not because they have more aneuploid embryos. And the same was studied later in a study with preimplantation genetic testing, in which the authors performed an in vitro fertilization, but before the embryo transfer inside the uterus, they analyzed chromosomally the embryos, and they only transferred the embryo if it was euploid. So after transferring embryos with normal chromosomes, if the patient presents obesity, there was a significant increase in the clinical miscarriage rate. So the message of all of this is that female obese women present an increased risk of miscarriage, but this is not due to an excessive chromosomal abnormalities in the embryos, but due to the abnormal environment in which the embryo develops. And this is the same reason why in obese women, there is an increased risk of fetal and maternal complications during the 3 trimesters of pregnancy. That include the increased risk of congenital anomalies. And all these risks lead to a significant reduction in live birth rates. And this is why in many studies have been described that as body mass index is higher, there is a higher chance of not having a live birth in a dose-dependent manner, as well as clinical pregnancies. And lastly, in recent years, there are several epidemiological studies that have shown that when the mother has a high weight during pregnancy because she started pregnancy with high weight or because she gained a lot of weight during pregnancy, there is an increased risk of metabolic and non-metabolic chronic diseases in the offspring. This means that probably the exposure of the fetus in moments of very critical for organ development in utero to an abnormal environment with endocrine, metabolic, and inflammatory alterations produce changes in the expression of genes in different organs that then will predispose them to develop during childhood, adolescence, and adulthood all these diseases that are more frequent when your mother was obese during pregnancy. So to conclude, according to all this information, we can say that obesity impairs natural and assisted conception. Obesity increases pregnancy complications and offspring diseases. Obesity seems to affect gametes, embryos, and endometrial receptivity, all the components. And of course, weight reduction before conception should be advised in obese women because it's the best measure to prevent or to minimize all these problems related to female obesity. Thank you very much for your attention.
Excellent. Thank you so much for so many details on our topic. So that indeed interesting and I am sure useful to all our patients. And well, now it is time for the questions. We do have a few of them ready. So, Dr. Jose, are we ready for the questions from our patients?
Okay, perfect.
Excellent, thank you. Right, so the first question is right here. I am petite, 5 feet. My BMI is over 30. I have hypothyroidism and fibromyalgia. Despite eating healthy, I'm not losing any weight because of fibromyalgia. I can't do rigorous exercise, only walking. I've been eating less calories, seen nutritionists, still no luck. It's very frustrating for me now. Can you kindly suggest any tips for me to lose weight?
Yes, of course. The best way to reduce weight is by the so-called lifestyle therapy. But lifestyle therapy is a combination of different parts with a multidisciplinary team in which, of course, the reduction of calories is important by the nutritionist, but this has been to compensate with specific training for the patient, psychological support, and endocrinological follow-up of the patient. By now, the only programs that have shown to be beneficial for improving fertility in women with obesity by reducing weight are those in which this combination has been performed of all these specialists: psychologists, nutritionists, personal trainer, and endocrinologists. It has been shown that the loss of weight can be significant to improve fertility after 3 months if the patient goes to the clinic with all these specialists at least twice a week. Because sometimes the problem that we have is that the patient perform exercise that is not good for her or for reducing weight in personalized way, because the way to reduce weight depends on the situation, the physical condition of each patient. Or sometimes the exercise is not enough to compensate for the calories that the patient is taking. So the combination of reduction of calories and increase of expenditure of energy is the best way, but this needs to be guided by a specialist and with psychological support, because as you know, many women with obesity tends to have a high weight because due to anxiety and other problems tend to eat not for hunger but for recomfort the situation. So my advice, of course, is to go to a multidisciplinary team with a close follow-up. This means at least 2 visits per week with the personal trainer, nutritionist, and psychologist, and at least every 15 days or 3 weeks, control with the endocrinologist in order to know that there is no negative implication of the approach, in your case, to your metabolism.
All right, excellent. Thank you so much. And actually, there is a follow-up from the patient, okay? So let me go to this straight away. Been trying to lose weight since 2012, but I think the thyroid plays a big role.
The thyroid plays a big role, especially in hypothyroidism, when it's not regulated. But once the thyroid function is regulated, the role is really marginal. So, of course, if you detect a woman with obesity and a severe hypothyroidism, usually if you control hypothyroidism, the part of excessive weight that is related to the
Hello?
probably the role in weight gain is really marginal.
All right, perfect. Thank you so much. But sorry, there is one more thing from the patient. Thyroid is regulated.
Yes, but probably this is not the problem of your weight.
Mm-hmm. All right. If you would like to add anything, just type it in, okay? And now Thank you so much, Dr. Jose, for answering that question. There is okay, this is like thank you from the patient right here.
Okay, thank you.
And well, let's get to the next question that we have. Do you think it's worthwhile doing a genetic carrier testing screening on our surrogate to make sure her blood is not carrier for anything that my husband and the egg donor are carriers for, as we don't want those carrier conditions coming through to any baby born?
Okay, I can ask you I can reply this question, but it's not related to obesity. This is about carrier testing. Carrier testing is today an option for monogenetic diseases. This means that are to avoid diseases, usually rare diseases, that are due to the presence of the same mutation in the same gene in both members of the couple. So, of course, is something that is really good, because if you detect that both members of the couple present the same mutation, you know that the risk of having the disease in the offspring is around 25%, as all the autosomal recessive diseases. So if you detect this situation, you can analyze the embryo after in vitro fertilization, but before embryo transfer, to discard those embryos with the disease. And it's the only way today to avoid the disease in the offspring. The problem really is a problem of money, because to test all the couples that want to have a pregnancy, not only by assisted reproduction, but also by spontaneous conception, because the risk is exactly the same, is really expensive. So from a point of view of public health, is not possible today. From the point of view of private settings, is possible, but it's an amount of money that the patient has to add to the money that they have to pay for the in vitro fertilization cycle. Sometimes this is the problem, because a complete testing of all the possible mutations today, that are more than 500, is around 1,000 to 1,300 euros per person. So it's expensive, and sometimes the reason why some patients do not want to perform the test is because problems of cost. But of course, if the test is cheaper in the future, is always that is advisable in patients in order to cut these rare diseases that can occur in assisted conception, but also in spontaneous conception.
All right, excellent. Thank you so much. And actually, there is a follow-up from the patient, okay? Just additional information. Yes, we will do PGD. We have tested the donor already. It's not expensive. It's only $250 in the US of the 301 carrier screening, 288 general panel, and 13 add-on genes.
Yes, it depends. Of course, it depends of the number of diseases that you discard. In Spain, it's the same. There are different prices, because it's not the same to discard 50 diseases that 100, 300, 500, etc. The cost in Spain, around 1,000 euros, is when you discard more than 500. I think, I don't remember correctly, but I think that around 547.
Excellent. Thank you so much for clarification, of course, and well, your question. Now we have a question that is like, it has to, oh, sorry, there is a follow-up, so I just want to add it, okay? So would you recommend having the surrogate screen so epigenetic comes into play in a negative way?
But I don't understand the question. Epigenetics, you refer to the epigenetic induced by the surrogate mother?
Yes.
The problem, yes, the problem is that the epigenetics, as far as I know, cannot be tested in any patient. Epigenetics means that the change of DNA, that is genetics, is normal, but epigenetics is the way these genes are expressed or not. So sometimes genes that don't have to be expressed are expressed and can induce a disease, or just the opposite. Some genes that have to be expressed are not expressed. And the way these genes are expressed or not depends on the environment in which the embryo and the fetus develop. Of course, there are conditions in which there are clearly epigenetic modifications. For instance, if a mother takes drugs or alcohol, there are induction of some epigenetic modifications in the embryo genome that can increase the risk of diseases in the offspring. And of course, obesity is one of these situations, because it has been established that the risk of offspring diseases in obese women is due to the epigenetic modifications that the abnormal environment, metabolic and endocrine environment of the uterus can induce. But the way try to avoid those genes to not be expressed. No, the only thing that we can do today is, if we know that one condition can induce epigenetic modifications, is not to treat the genes or the expression, but to avoid the situation that induce epigenetic modification. So if you know that alcohol, drug, obesity, etc., can induce epigenetic modifications, the only thing that we can do today is to avoid these conditions during pregnancy. Stop alcohol, stop drugs, reduce weight, but we cannot maintain, for instance, obesity and change the expression of the genes. The only thing to avoid this abnormal expression of gene is to avoid obesity.
Excellent. And okay, got it. Thank you so much for clarification. Yeah, definitely difficult, but thank you again for that. Actually, there is a follow-up to our previous question, okay, from the previous patient. So you mentioned earlier to see nutritionists, the psychologists twice a week. Do you mean to see each one twice a week?
Yes, really. For instance, in our clinic, we have a program like this one, but we perform the visit one after the other the same day. The reason is that there are studies that have shown that weight reduction before IVF is useful for having a higher live rate, and there are other studies that have shown that this is not useful. The difference between these studies is that in the first ones, in which the results were better after weight reduction, in all of them, there was a close follow-up of the patient by a multidisciplinary team every week, at least 12 weeks. Only in these cases has been detected that the weight reduction achieved is significant and can improve the result of the IVF. On the contrary, some studies, even with bigger sample sizes, in which the patient was seen once a month or only by phone, but without close follow-up, and probably with a follow-up by a non-specialist, for instance, a resident of gynecology, but not nutritionist, not personal trainer. In these cases, the program has failed to produce a significant weight reduction and to improve the chances of conception after IVF. So only a close follow-up or by a multidisciplinary team has shown to date to be beneficial for weight reduction for fertility purposes, and especially when the patient has a very high body mass index.
All right, excellent. Thank you so much once again for your clarification and again for your question and additional one, of course. And now we will have two parts of the question, okay? So, hi, I have had 3 donor egg transfers with yourself at IVI Valencia. 1 failed, 2 both were low HCG under 20. My BMI was 43 at the time. Dr. P advised weight loss. I have since had weight loss surgery and my BMI has dramatically reduced. We hope to return in January. Would you suggest other tests? Embryos were blastocysts and great quality. No other health problems from either of us, just my weight. And also, if my BMI is now lower than 30, does this mean my MH will increase as it is very low?
Yes, one thing is that with 43 of body mass index, of course, is enough reason to have a failure in any kind of treatment, because endometrial receptivity is really altered even in ovum donation. This doesn't mean that it's impossible to achieve a pregnancy, but the chances of pregnancy are really reduced. As you know, in ovum donation, if we have a good uterus, good morphology, and good receptivity, that in this case can be altered by obesity, but if we have a good uterus, the chances are really high. But if the uterus is not okay from an anatomical point of view, or from a problem of receptivity, in your case probably induced by body mass index, the results are poorer. So, of course, if the only problem that you had was your body mass index, of course, the advice is to go ahead with a new ovum donation, and you don't need more tests. But what I don't need, what is your age? Because your question of anti-Mullerian hormone, what's your age?
38.
38. Okay. The problem is the following. As you know, anti-Mullerian hormone is a marker of the number of oocytes that you have inside your ovaries. And what is clear is that if you have a higher body mass index due to the volume of distribution of drug, despite a same level of anti-Mullerian hormone that another women, you will have a lower ovarian response. On the other hand, anti-Mullerian hormone in obese women usually presents lower values than real values. There are some conditions that can vary the level of anti-Mullerian hormone, reducing the real level. One of these conditions is the taking of contraceptive pill. Another condition is obesity. So my advice, if you want to see after weight reduction with your age, how is your anti-Mullerian hormone, the only way is to measure again anti-Mullerian hormone. If anti-Mullerian hormone was low because a false reduction induced by your weight, anti-Mullerian hormone will be higher. But if your anti-Mullerian hormone was low because your age, or because sometimes even being younger, you can have low anti-Mullerian hormone, the level will be as low as before. So the only way to know it is to repeat it. But the reason for repeating the anti-Mullerian hormone is only if you want to try now to go ahead with your own oocytes. Because if it's with ovum donation, it doesn't matter really.
Okay, sorry, there is additional information. We did try with own eggs. They never passed testing. This was when I had very high BMI.
Yes, you tried with own eggs when you had this high body mass index. Is correct?
Yes. Mm-hmm.
Yes. In this case, I think that you can have an opportunity. I will perform an anti-Mullerian hormone if I see that the level is not so low and you are 38, you can have an opportunity with your oocytes, of course.
All right, perfect. Thank you again for that. And of course, as you can see, there is a thank you from the patient as well. Thank you so much. All right, let's have a look at the next question we have ready. Sorry if I misunderstood, but if my donor has a BMI higher than 25 and my BMI is under 25, is there a chance I could still miscarry?
Well, the relationship of the donor body mass index is not with miscarriage, but to the chances of conception. So pregnancy rates, if your donor has a high body mass index, can be reduced. This is clear. Of course, the risk cutoff is from 30. But from 25 and 30 is a situation of overweight, as sometimes the quality of the oocyte can be also reduced. But this has not been proven. But anyway, in our clinic, for instance, we decided some years ago not to admit any donor with a body mass index higher than 25. But of course, between 25 and 30, there are doubts. From 30, in any clinic in the world has to be admitted a donor, knowing the information that we have today.
All right, excellent. Thank you so much for that clarification as well. Next question is right here. So please can I clarify from which BMI upwards are these negative issues more prevalent?
Yes,
BMI
from
30.
30. From 30, of course, 30 is only an isolated measure. And when we assess a patient, we only look for the distribution of fat, if it's a central distribution, if there is an implication in lipids, in glucose, if the age of the patient. So it's an isolated parameter. But of course, all the studies have agreed that from 30 is when the problems really start, and is in a dose-dependent manner. So as the body mass index is higher, all the problems that I have shown you are increased.
Perfect. Again, thank you so much for that clarification. Next question is up. I would like to know if I am 170 meters tall and my weight 90, is that too much, or which weight exactly for obesity?
Okay, I need my calculator, and I tell you now.
Okay, excellent.
You have 31.1 of body mass index, because is 17 square and 90 between the result that is 2.8. So your body mass index is 31. So you have obesity class 1, but is just in the limit. I tell you now what will be the weight that you have to lose to stay out of the obese definition. Probably with only 5 kilograms, you will have 29, that is overweight, but as I have told you before, this is not really negative for reproduction. So with only 5 kilograms, you will be okay. Of course, if you lose 10 or 15, better, but with only 5, you will be out of the zone of risk.
All right, excellent. Thank you so much for that help with counting that BMI index as well. And well, let's have a look at the next question. How would any metabolic condition actually act in causing a stillbirth if there is no pregnancy, diabetes, or preeclampsia, or any known infection present and the baby is not very small or large, no macrosomy? What actually can happen can be caused?
But in general or related to obesity?
I believe obesity, but of course, please just confirm that for us. Okay, Anne? Yes, someone is typing.
Okay, don't worry. I tell you both answers.
Sure.
In general, there are some stillbirth with unknown origin. It is not known, really. Sometimes there is no reason, apparent reason, because after the analysis of the baby, the placenta is all okay. And sometimes it's a compression of the umbilical cord, etc. But in the vast majority of situations, it's because there is any metabolic condition, diabetes, preeclampsia, as you have said, because there is a thrombotic problem that block the vessels that supplies the blood flow to the fetus. And sometimes there are situations of chronic diseases in which there is a subclinical inflammation of vessels that finally alter the blood supply to the fetus. And this is, for instance, the reason why in obese women there is an increased risk of stillbirth. The reason is the subclinical inflammation that occurs in this chronic condition. But as I have told you before, there are some cases of stillbirth in which after the study of the baby, chromosomes, discarding infections, chronic diseases, there is no apparent reason, and we don't know what has happened. But in some of these cases, the problem ha sido a umbilical cord pressure, compression. Sometimes the umbilical cord is around the arm, around the leg, and sometimes this is the reason. But and if placenta in your case was large, was not small, probably is an unknown case that sometimes happens. Sometimes we don't know what is the reason.
Okay, and actually patient has added,
Yes,
no reason
but in
was
this case, the good news is that when there is no apparent reason, the risk of recurrence is really low. So usually the problem does not repeat in a future pregnancy.
Okay, thank you for that once more again.
You're welcome.
There are like 2 questions left, so we will be slowly finishing. So if you have any questions left, this will be like the final call for those questions. So go ahead and type those in right now. And the question is here, can high BMI cause gestational diabetes or other complications when pregnant?
Yes. In fact, body mass index, increased body mass index during pregnancy and out of pregnancy can induce what is called comorbidities. Comorbidities are metabolic situations that can appear due to the obesity or can be before in the patient, but are increased with obesity. And this is why when we reduce weight in obese women, sometimes these situations are improved or even avoided. And it's clear, obesity increases all the type of metabolic disturbances that can appear in women, but this occurs out and in the pregnancy.
All right, thank you so much once again for answering this question. And there is another one right here. What is the risk of starting pregnancy with a TSH of 4 higher than the recommended 2.5?
Yes, really. Some years ago, it was believed that hypothyroidism, that is when you have a high TSH, low T4, and symptoms, was related to problems in the growth of the fetus and in the neural development. This is why this problem was related to mental retardation. But from some years ago to now, there is a new problem that is the subclinical hypothyroidism, that are women without symptoms, and the only way to determine if TSH and thyroid hormone are normal is by performing analysis. So what's happened is that in an adult person, a level of TSH can be normal because according to different labs, up to 4.5, 4.6 can be normal. So for your functions as an adult, there is no problem. But during the first weeks of pregnancy, during the first 16 weeks, more or less, your hormonal, your thyroid hormone, the T4, is essential for the neurological development of the brain of your fetus. And the problem is that during this time, the fetus does not produce this hormone. So the hormone comes exclusively from the mother. So if the level of T4 is normal, but in the lower range, sometimes the neurological development is not as good as it can be. So these problems are not related with mental retardation. These problems can be related to school retardation with hyperactivity syndromes, deficit attention syndrome. So if you have a lower level of T4, even in the normal range, you can have a baby with these problems. So it has been established by endocrinologists that when TSH is lower than 2.5 is because T4 is in a level that is good for your pregnancy. But if the level of TSH is higher, is because the T4 is lower. And this is the real problem. And this is why that as the same situation that we give folic acid to prevent spina bifida, that is the only malformation that can be prevented today, in every woman that wants to be pregnant, no matter if spontaneously or by assisted reproduction, we perform a TSH test. And if the TSH test is more than 2.5, of course, we measure T4 and T3, etc., but we give low doses of thyroid hormone in order to prevent these mild alterations in the brain development of the fetus. It's okay, the question?
Yes, all is good. Thank you so much, of course, for your answer and all the details and, of course, your question. There is actually one more right here, so let's have a look. Just curious, I have a neighbor who is obese. She has had 4 children, no IVF. She had her last child at 41. How do you explain this? She doesn't recall having any complications.
I have a neighbor with 3 car accidents that is still alive. It's an example. What I want to tell you is that a risk factor does not mean that it's impossible something. Obesity is a risk factor for having fertility and pregnancy complications. But if the risk is triple of infertility, in normal population, general population, infertility occurs in 15% of population. Triple risk is 45. Even in women that are really obese, you can have 80% of infertility, for instance, but you have 20% of normal fertility. So this is a risk factor. Not everybody that smokes has a lung cancer. I have friends that smoke a lot and do not have lung cancer. But this does not mean that tobacco is not related to lung cancer. I don't know if I have answered your question.
Well, thank you so much, because it is true. I mean, unfortunately, we cannot change that, right? Sometimes it's just easier for some other people, I'm afraid, right? Okay. There are like 2 questions in the meantime, okay, that popped up here. So I guess we still have some time. So let's go ahead with the question here. My TSH is high, 3.24. What kind of medication would you recommend to balance it down to 2.5?
Really, the level that you have is not really high. And when the level is not really high, usually is repeated, because sometimes you can have isolated peaks of TSH. Anyway, if the level persists over 2.5, usually what is given is thyroxine. Thyroxine, that is T4, and usually is given in low doses. Usually 25 or 50 micrograms per day is enough in your case. But my advice is that this is an isolated level. Please repeat it in order to be sure that is maintained on time.
All right, excellent. Once again, thank you so much for that. And at least for now, it looks like this is our last question. So let me show you what can be done if T3 is a bit low. My TSH is good at 1.1 and T4 was 5, but T4 just 3.7. IVF doctor thinks nothing needs to be done. Sorry, T4 was 15. Okay, not 5, 15.
Your T4 is high and your TSH is normal. This is the question. Is this the question?
IVF doctor thinks nothing needs to be doing, so I guess
yes. But T3. Because T4, sorry. T3 is high or low? Sorry, but
T3 is a bit low.
But T4 is normal and TSH is normal.
Just let me check, okay? And let me see. T3 is low.
Yes, okay. But the remaining hormones, TSH and T4, are normal. In this case, you don't you don't need to do anything.
T3 should be 4.5 to 6.
Yes, T3, yes, don't worry, because usually endocrinologists, as T4 is the more stable hormone in order to determine the function of the thyroid gland, if they see that TSH and T4 are normal, usually they don't consider the level of T3.
All
This
right,
is what the endocrinologists that know more about this issue than me say.
All right, excellent. Thank you so much indeed for clarification, of course. And well, one more question, okay? As we
you're welcome.
Okay. So I have PCOS and have been struggling with weight issues all my life. Have tried IVF with own eggs without success. I have had 3 spontaneous pregnancies last 2019, which have ended in miscarriage. So I am now turning to donor eggs. When should you understand to quit and go with last option, surrogacy? And my BMI is 31, but otherwise I am healthy.
31 is not really high to consider that is related to three spontaneous pregnancies, 3 miscarriages. So probably your level of body mass index, 31, is not a reason enough for having recurrent miscarriage. I don't think that this is the reason. For on the other hand, polycystic ovary syndrome probably is not the reason either, because in polycystic ovary syndrome there is a controversy about if it's related to miscarriage or not, but it's not clear. What happens in polycystic ovary syndrome is that usually you can have a higher number of oocytes, and many of them are not good, but the remaining oocytes are good, and finally we have good embryos. This means that if in a women without polycystic ovary syndrome we obtain 8 oocytes and finally, for instance, 4 embryos, in a women with polycystic ovaries we can have 20, but finally 4 embryos. This is why when there is a comparison between the results in terms of clinical pregnancy rates and live birth rates between polycystic and non-polycystic ovary syndrome women, the results are exactly the same. They produce more bad oocytes, but the good are in the cohort of oocytes that we take. Your age, 46. So I think that with polycystic ovary syndrome and your body mass index, these are not the reasons of your miscarriages. But if you are 46, this is the reason. If we discard any other problems such as uterine problems, thrombophilia, chronic diseases, of course the reason is your age, because last year you had you were 45, and if the 3 miscarriages occur from 40 years, probably this is the reason. So you have 2 things to do. One thing is to perform an in vitro fertilization with preimplantation genetic testing to discard abnormal embryos, but with your age, probably all of them will be abnormal. And the second option that I will advise you is to perform ovum donation.
All right. Thank you.
Because the problem is the oocyte due to your age. It's not your weight, it's not your polycystic ovary syndrome.
Okay. Thank you. And we are just having like 2-3 questions in regards to the male TSH. Also, if it's below 2.5 before giving the sperm sample for IVF.
Really, the men initially, if your husband has no symptoms, there is no problem. There is no reason to measure TSH. And if he has symptoms, he has to be treated as everyone, but there is no clear relationship with the quality of sperm if the hypo or hyperthyroidism is not really severe. So in your case, if your husband has no symptoms, as is okay, there is no reason to measure TSH. There is no importance of this level.
All right. Excellent. Again, thank you so much. So just one more short question. Does male BMI affect sperm?
Yes, affects. But As I have shown in my presentation,
Yes.
the alteration is difficult to be seen by the conventional methods of sperm analysis because there is no clear effect in concentration, motility, and morphology, but finally the results are poorer in men. The thing that happens is that sperm, as you know, is not so important as all the components of women, because in women you put oocytes, the embryo, the body of the embryo is the oocyte, the chromosomal complement of the embryo is earlier altered in women than in men, and finally the uterus is yours and the pregnancy is yours. So I can tell you with this that probably the contribution of the sperm to all the process is 10% and 90% is women. So this is why when we have an obese man with a normal weight women, probably the effect is mitigated, but on the contrary, is not. But of course, affects, and if both members of the couple are normal weight, is the best situation, because even in a spontaneous pregnancy, the combination of obesity in both is related to a reduced spontaneous conception. So the answer is that has a negative effect, but the negative effect in the considering all the components that contributes to the achievement of pregnancy and ongoing of pregnancy, probably the aspect of the sperm is the less important.
All right, excellent. Thank you so much. And well, there is one short question, a little bit different one. So is it best to do PGD on all embryos?
Of course. If you perform preimplantation genetic testing for discarding aneuploidies, chromosomal abnormalities can appear in any chromosome. Of course, there are some chromosomes that are more frequently altered by different conditions, such as advanced age. But sometimes other chromosomes that are less frequent can be affected. And the problem of chromosomes is that sometimes we are focusing on those chromosomes that are more related to miscarriage or to Down syndrome, such as chromosome 15, 16, 18, 13, 21. But there are other chromosomes that when are reduced in number, instead of trisomy, monosomy, only one in a pair, can be related to infertility, to no implantation. So, of course, if you perform a preimplantation genetic testing, the advice today is to analyze all of them, because each one of them with more possibilities of having alteration or less possibilities, but each one of them can induce a different problem. No pregnancy, miscarriage, or a baby with any alteration. And today, technology can give us in the same time and with a similar price, the analysis of all of them. In young donors, there is no reason to perform preimplantation genetic testing. In fact, for instance, in Spain, we cannot do it because by law, all the donors are below 35. And recently, there is a study published in which young women below 35 were randomized to perform preimplantation genetic testing. One of the groups, a group of patients, a group of young women, and other group of young women were not didn't undergo preimplantation genetic testing, and the embryos were directly transferred without analysis, and the results were exactly the same. So to perform a preimplantation genetic testing in a young woman has no reason to be performed, no reason. Of course, you can discard a Down syndrome, but what is the risk of Down syndrome in a young woman? Is really low. So if you analyze a big sample of patients, young patients, one group with preimplantation genetic testing and another group without, the results in general are the same. So there is no reason to pay for this, and there is no reason to do it because you are not going to improve the result.
All right. Perfect. And thank you so much. And I believe this is our last question. So Thank you so much to everyone for joining us tonight, for your questions. I'm sure it has been quite useful for you. And well, Dr. Jose, thank you for joining our Stronger Together initiative, and also for your assistance, for your great presentation, and also answering all those questions. And well, is there anything you would like to add?
It has been a pleasure for me to be with you. I'm in IVI Valencia, and if any one of you has a question, you can directly send me an email, because my email, I think that is in my presentation, and I will try to help you.
Excellent. And of course, you can use the link I have just sent you in the chat section as always. And of course, that way you can also get in touch with Dr. Jose and his team. There is an option to ask your questions if you would like to get some more details. And well, Dr. Jose, as you can see, there are more thank yous coming your way right here. Definitely want you to see those. So there is one more. Thanks. It was an interesting webinar. So thank you so much once again, everyone. Sorry, everyone, I just want you to thank again. And of course, this has been recorded, so you will be able to watch this on myivfanswers.com. And of course, I can encourage you only to subscribe to our YouTube channel, so when the video is uploaded, you will be notified about that. So go ahead and do it. And of course, there are two more events tomorrow on Friday, so I hope you will be able to join us as well. And there are plenty more coming next week as well. So as always, I encourage everyone to go ahead and register to save your spots. And once again, okay, I can see a question for me. Presentation of surrogacy. Okay. We can, yes, I remember that. At least for now, nothing on sperm cord cells. Okay, so sorry about this, Angela, but of course there are some more coming our way. So possibly nothing yet, though. Okay, I hope that's okay. And but I remember that. I remember you have mentioned this before. So thank you, Angela. Thank you so much. And well, Dr. Jose, once again, thank you so much. Have a lovely evening. And that was definitely an interesting webinar tonight. And well, I just hope we will be able to simply do it once again on yet another topic. There are plenty of topics to discuss as well.
Okay, thank you to all of you.
Thank you. Take care. Bye.
Bye, bye, bye.